The regulation of flow is based off of various types of signals. The most important of these signals are the autocrine and paracrine signalings, in particular the bradykins and the kinogens. Most important of these bradykins and kinogen signals are the nitrous oxide, NO, as well as endocrine signaling from TNF-alpha, inflammatory signals such as interleukins, as well as hormone and endocrine signalings within the renin-angiotensin and antidiuretic or vasopressin signaling. We also have signaling based off of hyperthermia and hypothermia that's going to regulate the diameter of the vessels based off of baroreceptor responses. We also have nervous system signaling, primarily from the autonomic nervous system via sympathetic as well as parasympathetic signaling. And we have issues of cardiac drift and cardiac shift. We're going to look more detailed into the cardiac drift and cardiac shift in a few minutes. It's basically going to dictate where flow of the blood's going to go based off of metabolic demand. So let's take a look at the neurological regulation of the blood pressures. This regulation is based off of three distinct feedback loops. The three distinct feedback loops are the baroreceptor feedback loop, the chemoreceptor feedback loop, and the proprioceptive feedback loop. The proprioceptive feedback loop is primarily localized, and is primarily localized within the overall cardiac drift and cardiac shift that we see when we have movement and activity. All of the feedback loops will be involved within the baroreceptive feedback loop that we're going to take a look at next. So let's take a look at the baroreceptive feedback loop. This is a pressure based off pressure sensitive receptors within the internal carotid artery and other large arteries, in particular the aorta, within the thorax. It's based off having a constant action potential rate until we get a stretch. Once we get a stretch, we start having a lower action potential rate, or when we have a compression, or we have a higher action potential rate. If we drop the action potential rate, we end up getting an increased sympathetic tone. If we have an elevation in action potential rate, we end up having an increase of parasympathetic tone. In the chemoreceptive part of this reflex loop, we have receptors that are going to be located within the carotid sinus and aortic arch, and what they're going to do is they're going to detect signals of hypoxia, hypercapnia, and acidosis. What this is going to do is it's going to change sympathetic tone based off of the change of acid level as well as the change of ion level. So let's take a look at these reflex loops. If we have a signal of too low of pressure, or we have some sort of external or internal stressor, we end up getting a change of autonomic tone leading to an increase of sympathetic tone and a reduction of parasympathetic tone. This leads to a vasoconstrictive response. This vasoconstrictive response leads to an increase of luminal resistance and an increase of overall blood pressure. On the other side, if we happen to have a signal of too low of pressure, too high of pressure, what we end up getting is we end up getting a signal that will lead to a vasodilatation response. This same thing happens when we have a reduction of the stressor. What this does is this increases the parasympathetic tone and decreases the sympathetic tone. We get that vasodilatative response, which means that we get a decrease of luminal resistance and a decrease of blood pressure. What can happen in a baroreceptive reflex is we get a drastic drop of blood pressure due to gravitational pooling in lower extremities. What this does is this causes an instantaneous too low. This instantaneous too low is met by systematic and systemic vasoconstriction. This systematic and systemic vasoconstriction can lead to that lightheadedness and that dizziness that you may experience, or that older individuals definitely experience, when they change body positions too quickly, or when they go from a lying to a standing position too fast. So let's take a look at the hormonal regulations that we have at play here. We have what's referred to as the RAA system, the renin-angiotensin-aldosterone pathway. We have the sympathetic, epinephrine, and norepinephrine pathways. We have the antidiuretic and vasopressin, and we have what's known as atrial natriuretic peptide issues or pathways. The ANP pathway, the atrial natriuretic peptide, is going to increase parasympathetic tone. It's a hormone that's released from the right atria when there is too much load on the right atria. And what it does is it causes the kidneys to decrease the amount of water that's being retained, while also causing a vasodilatation response throughout the body. The RAA, the epi-norepi, and the ADH pathways are going to do the exact opposite. They're going to increase sympathetic tone, and they're going to increase the retention of water at the kidneys, as well as at the sudoriferous glands, in an attempt to get blood volume back up to normal, because it's a sense of dehydration, or try to get blood pressures back up to normal in order to get perfusion rates back to normal. So let's take a look at the RAA pathway. We end up starting with a signal of low peripheral resistance or low blood volume. This low peripheral resistance or low blood volume leads to low perfusion in both the kidneys as well as the liver. In the kidneys, this low perfusion rate leads to a release of renin. In the liver, this low perfusion rate leads to a release of angiotensinogen. Angiotensinogen reacts with renin within the bloodstream to convert to what's referred to as angiotensin 1. Angiotensin 1 is an inactive form of the chemical. Angiotensin 1 interacts with a converting enzyme, which we call ACE, angiotensin converting enzyme. Angiotensin converting enzyme is released from both the kidneys as well as from the lungs when there's low rates of perfusion. ACE converts the inactive angiotensin 1 to the active angiotensin 2. If someone goes onto an ACE inhibitor, what it's attempting to do is it's attempting to reduce the conversion from angiotensin 1 to angiotensin 2. Angiotensin 2 has ubiquitous receptors, which means that there are receptors throughout the body for it. In the vasculature, it's going to lead to a vasoconstriction as well as an increase of peripheral resistance. At the kidneys, it's going to lead to an increase of sodium retention. The increase of sodium retention is going to lead to an increase of water reabsorption. It's going to combine with aldosterone released from the adrenals to increase potassium excretion, leading to an increase of sodium reabsorption and water reabsorption with the sodium. The change of action at the kidneys is going to lead to a decrease of urine volume, retention of water, and movement of water back into the bloodstream to increase total blood volume, hopefully getting enough total blood volume and enough vasoconstriction to inhibit the initial signals of low peripheral resistance or low blood volume. At the same time, angiotensin 2 will stimulate the posterior pituitary to release vasopressin or antidiuretic hormone, which will add to the signaling coming from angiotensin 2 at both the kidneys as well as at the vasculature. So if we look at this, renin is going to act with the angiotensin converting enzyme to activate angiotensin 2, which is going to allow for a return to normal blood volume and a return to normal blood pressure. Epinephrine and norepinephrine are going to be released and act as a sympathetic response, primarily acting on the nicotinic and muscarinic receptors within the vasculature, as well as the alpha adrenergic receptors to lead to the vasoconstriction that we see in response to their release. Antidiuretic hormone is going to be released from the posterior pituitary in response to that decreased blood volume, primarily in response to a dehydration signal. Whereas the atrial natriuretic peptide is going to be released from the right atria in an attempt to reduce the amount of atrial pressure that is being exhibited. In addition to the endocrine signaling and the neurological signaling, we end up having autocrine and paracrine regulation. Most of the autocrine and paracrine regulation is going to be related to regulation of anastomotic junctions and collateralization of flow. This is going to allow for the body to change where blood is moving due to metabolic demands. The principal signals are going to come from interleukins, ILs, adipokines, in particular adiponectin, the amount of adenosine triphosphate and adenosine in circulation, serotonin, abbreviated 5-HT, and nitrous oxide. What this is going to do is this is going to lead to a change of blood flow within the anastomoses and within the collateral lines of flow within the vasculature. It's going to do this by controlling the sphincters at the anastomoses to either lead to vasodilatation, increase of blood flow, as you see on the left image, or vasoconstriction to decrease blood flow, as you see on the right image.